One of my great interests is how clinicians think. There's a lot of work that's been done on how physicians think. Elstein, Schulman, and Sprafka published a textbook back in the 1970s or 80s that really talked about how physicians thought. Much less work has been done on how nurse practitioners think. This talk is actually an amalgam of various information from the research both on physicians and nurse practitioners. I encourage feedback. I would love to hear what you guys think, but I do think that there's some really good things that you can use in this that will help you be a bit more metacognitive. So how do people think? How do clinicians think? The majority of clinicians, as shown by the physician research, will see a patient and they'll start to generate hypotheses in their mind. This is thought of as hypothetico-deductive reasoning. The other way to collect data is to use a menu, basically. So if you're going to use a menu, you basically have a list: medications, past medical history, etc. If you're trying to come up with a diagnosis, then generally hypothetico-deductive reasoning is going to be a lot more useful for you. Now, most people, when they create these hypotheses, will also think about some other different possibilities. And the average person keeps at least 3 to 5 possibilities in their head, and this is known as the differential diagnosis. And so you generally try to think about both the most probable and the most dangerous things that something could be, and then you think about how to rule those things in or out. And then you go based on your hypotheses that you have, and you figure out how to come to a working diagnosis. When you come to a working diagnosis, then you have to develop some therapeutic options, diagnostic options, etc. So the evidence seems to be that physician and nurse practitioners' clinical reasoning are pretty similar. There are some articles that do suggest that there are some nuanced differences, but that in general, when one is doing diagnostic reasoning, the process is going to be very similar. I cannot emphasize enough how important it is to come up with the correct diagnosis so that you can then choose the correct therapeutic options. So again, let's go back to this concept of hypothetico-deductive reasoning. For a lot of people going into the nurse practitioner role, this is a major shift of going into that advanced practice role. Becoming fluent in this process is a challenge. A lot of people want to use the nursing process, the assessment, diagnosis, plan, intervention, evaluation, but really the assessment and diagnosis are conflated here, and one really develops the ability to develop a thorough differential diagnosis. Using the appropriate differential diagnosis is key. As noted, the average person keeps usually 3 to 5 differential diagnoses in their head. Any less than that, you're likely to have premature closure and come to some sort of a conclusion that's maybe faulty. Any more than that, you end up spending hours and hours and hours trying to rule things in or rule things out. An experienced clinician is going to be able to do this very well. Obviously, as noted, you consider the most probable and the most dangerous causes. Most dangerous does not necessarily require diagnostics other than history and physical to be ruled out, but obviously you do want to keep it in your differential. Your inquiry strategy, which is how you choose to collect data, whether it's history and physical, whether it's diagnostic options, etc., is key, and really understanding what those diagnostic and therapeutic options are is, of course, very important. So this is a clinical reasoning process as defined by Howard Barrows and Garfield Pickle. This was a book from the 1980s. And basically it notes that you're going to collect data. You're going to have patient information here. Then you're going to perceive that data. You're going to analyze that data, and then you're going to come up with some sort of a problem and then generate it into a hypothesis of what it is that you think is causing that problem. That then creates an inquiry strategy. That might be just history and physical. At that point, you choose to collect that data, gives you more information. You then have to perceive that information, you analyze that information, and you'll go around this wheel probably 3 or 4 times with every interaction. Once you create a working diagnosis, you can exit the wheel, probably here, and then use your diagnostic options. Sometimes your diagnostic options are a trial of therapy, but depending on what response there is to therapy, you actually may have to return to the wheel. So with the therapeutic reasoning, basically you have to decide to treat. Once you've decided to treat, you will have to decide whether you use a non-medication option or a medication option. Non-medication options such as ice, heat, physical therapy, counseling, etc. are obviously a great way to go. Sort of beyond the scope of this discussion, when you do decide to use a medication, then you have to decide, is there any other laboratory data that I need to look at? Do I need to make sure their kidneys are okay? Do I need to make sure their liver is okay? Do I need to make sure they're not pregnant? I always specifically ask the patient if they have allergies, and using the chart is an option. But I think it's far safer to specifically ask people, because lots of times they will give you history that is not in the chart or is completely contrary to the chart. Cost and compliance. Sometimes I look things up on GoodRx just to see roughly how much this thing is going to cost. We have to figure out whether the insurance is going to cover it. Once a day medicines always have a much higher compliance than twice a day. Twice a day has higher than 3 times a day. And basically you need to look for barriers and things that are going to keep this person from actually complying with the treatment. What's the drug of choice is a key thing to think about. Don't ever just choose something because of convenience. Figure out what the literature says the actual drug of choice is. If you deviate from the drug of choice, that's not necessarily unreasonable, but you may actually want to put in your note why you're deviating. Again, there's lots of different reasons to maybe do that. Patient has diarrhea already, and you don't want to give them a medication that might increase their diarrhea, such as metformin. Cost is obviously something that might keep them from getting it filled. Many people have a philosophy that they don't want to be on narcotics, they don't want to use birth control, those kinds of things. You need to make sure that you're on board with their beliefs. And so on. Again, as noted, you can see that compliance decreases as we increase the frequency of the medicine each times of day. So algorithms can be really useful for prescribing. The problem is that people have very many individual characteristics, and it's essentially impossible to use algorithms all the time. The Sanford Guide is a great place to start, but to be honest with you, at least 25% of the time I can't use the medication because of an allergy, because they have used it before and they didn't like it, because of cost, you know, as noted, many different reasons. This is a place where many times experienced clinicians will have already thought through these kinds of things, whereas less experienced clinicians will just go ahead and prescribe based on the algorithms. An example of this is sinusitis. The Sanford Guide tells you to use long-acting Augmentin. Long-acting Augmentin is extremely expensive and hard to find. Most patients will not comply with it. So this is one that if you are going to use that, you want to make sure that you check with the insurance. You make sure that you understand all the implications of prescribing it before you use that. So getting back to differential diagnosis. So many people, when they have a differential will add a lot of zebras. There's an old saying that if you hear hoofbeats, look for horses before you look for zebras. In other words, if you have a patient and they have a headache, it's going to be more likely to be a tension headache or a migraine than it is to be a brain tumor. That being said, sometimes it's logical to include those serious kinds of things on your differential and ask at least a few history questions to drop them way down on your differential. Some things are going to be extremely rare. You know, a patient that has abdominal pain here in the United States probably does not have Chinese liver fluke disease. So just be careful coming up with all these zebras. As an infectious disease a doctor that I talked to one time said, well, don't forget the common things are what we commonly see. So the common stuff is going to be way more likely to present its head. On the other hand, don't miss something just because it is unusual. As noted, you keep 4 or 5 things in your head. And remember, you don't need a diagnostic necessarily to rule something out. You can probably rule things out just by history. So one of the defects in clinical reasoning is people that become way too certain way too quickly. This is something that a lot of inexperienced clinicians will do. Patient comes in and they have a positive rapid strep. You say they have strep. Well, the problem is that they may be a carrier, they may have mono, they may have trauma, they may be a gay male that has risk factors for gonorrhea in the throat. You just need to make sure that you do the differential even when you have something that looks like a very obvious diagnosis. So make sure you go through that process. Think of 3 to 5 things. Take a thorough history and think about all the different possibilities. One of the associated issues is people that anchor. Someone that comes in and they have back pain. And the person says, I think they have a UTI. Well, if the urine comes back normal, there's some people that go, well, no, I still think they have a UTI. Well, you have to be open to other possibilities. You can't just choose something and stay with it just because your gut tells you that. You have to be a lot more deliberative in your thinking. This is an example where this man presented with flank pain, hematuria. It was really clear that he had kidney stones, right? Well, maybe not. This is an example of where you need to keep your differential open. This person had some exam. I always say when all else fails, examine the patient. And in this case, I think if you would really examine this patient, you would have seen. But you do need to keep your eyes and mind open to all possibilities. Another issue that people often have in their clinical reasoning is not letting it be guided by hypotheses. This is the challenge of trying to be menu-driven and come up with a diagnosis, because unless you have some ideas of what something is, you're not collecting the right data to really support or dispute those diagnoses. So unfortunately, these folks end up collecting data for days at a time sometimes. Menu-driven versus hypothesis-driven. Hypothesis-driven is always better as far as trying to come up with a good diagnosis. On the other hand, you really often need to do some menu-driven after that just to make sure that you do have a thorough medical history, that you do know all the medicines that they're on, those kinds of things. So sometimes that data will have been collected by your medical assistant ahead of time, but you may want to validate that information. A lot of people, when they're working on a differential, will actually, sorry about the little interruption, but just thinking about people that want to do one hypothesis at a time. Sometimes that makes perfect sense. If you have somebody that doesn't have insurance, sometimes you do need to do one test at a time. The problem is that it can be weeks before you really come up with a diagnosis. So consider the options. once you've sort of tried to arrive at a working diagnosis, some people have a hard time sort of pulling the trigger on that. You know, is it X? Well, I want to do more testing, and I want to do more testing. The problem is that at some point, depending on what the issue is, you've got to make a decision and move on. Depending on the severity and the dangerousness of the treatment, sometimes you just make a decision, treat the person, and then if they don't get better, you can always do more testing. So just don't fall into that trap. Remember that when you do put down your diagnoses, most diagnoses have an ICD-10 code for most things. Knee pain is a good ICD-10 code. Actually, now it's usually right knee pain, initial visit. So we can talk about coding as time goes on, obviously. And when you're thinking about this, you have to ask yourself, how will any test that I do really change the outcome for this patient? So patient has knee pain, I'm going to get an MRI. Well, you're not going to do the surgery. So how is that MRI really going to help you? It might, but in many cases it doesn't. And then the patient is saddled with a $3,000 bill. And you really know little more than what you did before because you had a completely stable knee on exam, but you didn't know what to do, so you just went ahead and ordered an MRI. So Jerome Groopman, who is a surgeon, had published a book in 2007 called How Doctors Think. In it, he included 5 other possible reasoning errors, and I think these are worth reviewing as well. Representative error is the situation in which you see a case and you then generalize that case for years to come. So in other words, oh my God, I had a patient 30 years ago who was a 30-year-old woman who had stomach aches and she had colon cancer. We had better get a colonoscopy. Not that that's necessarily a bad way of a reasoning, but you have to be very careful to make assumptions based on previous cases, especially if there were unusual cases. So, you know, you have to be careful to take a few traits and then make that same diagnosis. That can also be called an attribution. Search satisfaction is where you go looking for something, you find something, and then you stop looking. Before you've sort of done your due diligence. Rapid strep's positive, therefore they have strep. Got to think that through. You know, they have nitrates in their urine, therefore they have a UTI. So either way, you've got to definitely think these things through and do a thorough evaluation before you settle on that. Framing is an interesting way of perceiving things. We all frame things, and in fact, sometimes the way a patient frames something, oh, it's really not bad, I don't mind it, you know, is going to very much change the way that we perceive things, as opposed to the patient that comes in and says, oh, I have really severe pain, I have this, I have that. So you have to be very careful to make sure that you're not going beyond what the raw data is telling you. So, you know, you also can have issues in regards to framing, in regards to the way that you present things to patients as well, meaning that if you give people options and they think of the options as being real serious, they're going to choose one way, and if you frame it as less serious, they'll choose the other way. Availability is, you know, you saw 4 patients that had the flu, the next person that has a temp of 102 and aches all over, oh, they've got the flu too. Well, maybe they've got Lyme disease. Maybe they have something else. So again, you have to think things through, make sure everything fits, and then you can go from there. Patient activation. This is an error that often happens because you don't do it. You have to be very cognizant of what the patient thinks is going on. Not that that completely defines what is going on, but you have to really have a sense of what they think is going on and make sure that everything fits. Osler, who was a famous physician, he was Canadian, but he was the head of the medical school at Johns Hopkins, has the old saying, let the patient tell you the diagnosis. So lots of times if you do a thorough enough history, they'll let you know what's really going on. Confirmation bias and single causality bias are two other possibilities. Confirmation bias is where you ignore things just to make things fit. I have patients who have been to Lyme literate practitioners and have been told they have Lyme disease. These people have ignored the fact that their family history shows that they have histories of rheumatoid arthritis, and in fact, a percentage of these people we have diagnosed with other conditions. Not all Lyme literate providers are like this, but unfortunately some, if you go to them, they'll make a diagnosis of Lyme disease. If you test negative, they'll make a diagnosis of seronegative Lyme disease. There are people who have really serious symptoms that are suffering. And sometimes these Lyme literate folks really do help them out. Other times, unfortunately, they lead them down a road that is not the best road for them. Single causality bias is where you think that everything's going to cause all the patient's symptoms. That's not always the case. One of my favorite riddles is, what can you sit on, lay on, and brush your teeth with? The answer, of course, is a chair, a bed, and a toothbrush. Just because you want one thing to answer everything doesn't mean that it does. So, you have someone that has joint aches and high cholesterol. You're going to say, oh, well, it's their high cholesterol medicine that's causing the joint aches. Maybe yes, maybe no. You have to think it through very carefully. So just in summary, always be careful to think problems through carefully, be metacognitive. Think about how you're thinking about things. What do I think's going on? What else could it be? What does and doesn't fit with each of my ideas on my differential? And then what diagnostic options, both history, physical, laboratory, and imaging options that one might have. So many errors can be made, but if you're very careful and thoughtful, you'll generally be a very successful clinician.